So today actually thought of starting pancreas, but in view of examination tomorrow, I thought pancreas, particularly acute pancreatitis, being an important topic and an essay question for you, I thought I'll take it some other day. So today we'll finish up the rest of the topics in stomach. So gastrointestinal tumors are nowadays more and more frequently diagnosed, and they are the soft tissue tumors of the stomach mainly. So throughout the GI system, these stromal tumors are there, but 50% of them are in the stomach. And they are due to the mutation in the tyrosine kinase c-kit oncogene. So this is the reason, that's why tyrosine kinase inhibitors are used in GIST. This is popularly called as GIST. So though they are called as tumors, they are both benign and malignant. You have to suspect malignancy if the size is more than 5 centimeters and high mitotic index. So more than 10 per high power field, if the mitotic figures are seen, then you have to suspect malignancy. And of course, if they are metastasizing to peritoneum and liver, then it is definitely malignant. So these are the 3 points to say GIST is either benign or malignant. One is size more than 5 centimeters, mitotic index that is more than 10 for high power field, and metastasis. Peculiarly, these lymph node metastases are rare in GIST. Okay, so they have equal incidence in both males and females, and common symptom is bleeding, or for incidental, for some other problem, endoscopy is done and it is found incidentally. Otherwise, there are vague symptoms like indigestion and all. Anorexia, asthenia, all these things may be there. So why they are, we are unable to diagnose accurately is because overlying mucosa, because this is from soft tissue, that is mesenchyme. So overlying mucosa is normal, that is the problem. Okay. Of course, with the introduction of endoscopic ultrasound, we are able to not only diagnose the mass, we can even biopsy it with either needle or targeted biopsy we can do. So what is the treatment once you have diagnosed it? It has to be, the primary treatment is surgery. Depending upon the size of the tumor, if it is small, you can do what is called as wedge resection. So suppose tumor is here, what you can do is, you can do wedge resection like this, and then anastomose, again back. Like that you can anastomose. So that is called as wedge resection. Of course, if it is tumor is large, then some form of gastrectomy, maybe subtotal or partial gastrectomy, you can do. So the drug of choice, already I told you, is imatinib. So imatinib, you have to continue almost because we do not know when it recurs. So for large tumors and highly malignant tumors, you have to continue imatinib. So this treatment for other areas just also same, excision of the mass along with the organ involved, either part excision or complete excision of that organ you have to do. Second common site is in the pelvis. So have to be any hypogastric mass can be a cyst, right? So that's about gist, and it is not a question for you, but you have to think of gist. If it is not carcinoma stomach, then you have to think of gist. Another tumor that is also seen in stomach is lymphomas. These are also after gist, these are common. So two settings are there. One is general lymphoma is there, say chronic, this non-Hodgkin's lymphoma may be there. Then as a part of generalized involvement, stomach is also involved. That is involvement in generalized lymphoma. But sometimes only tumor in the stomach, nowhere else. So the problem is nowadays with this H. pylori infection, the incidence of lymphomas are increasing because now they are forming about 5% of all gastric neoplasms, localized cyst. Okay, so there is B cell thing that is, as you already know, MALT, that is mucosa associated lymphoid tissue, that will be developing into lymphoma. And so it is common in sixth decade. What is this sixth decade mean? What is sixth decade? What exactly is sixth decade? Yeah, 2-6 you have answered correctly. Rest of the people who have answered are not correct. So it is between 50 to 60. That is sixth decade. After 50, one will attain sixth decade. Okay, 51, 52, 53, all those things are sixth decade. So it is common between 50 to 60 years of age. There may be big symptoms like pain, weight loss, and bleeding. Bleeding will bring attention to most of the gastric tumors, including carcinoma. This bleeding may be occult and it may result in malignancy. So the diagnosis is by endoscopic biopsy, like any other gastric tumors. And you have to exclude general lymphoma, generalized lymphoma, by doing CT chest, abdomen, bone marrow, aspiration, and complete blood count. So that if there is any generalized form, you can diagnose. So suppose it is localized disease, then what you do is surgery. Like anywhere else, localized lymphomas in other organs also, say we have already learned in thyroid. So you can do some form of gastrectomy if stomach alone is involved. Whereas if you have found that it is generalized disease, then for that already they might have started chemotherapy. So many regimes of chemotherapy are available. So can you tell me for lymphoma what are the regimes? Yes. So I asked about chemotherapy. You are giving other regimes. chemotherapy regime. Lymphomas. You have not heard about the regimes for lymphomas. So, yeah. Not a single, yeah. One answer I got is good. 45. CHOP regime, good. Very good. So, it is... so many regimes are there for lymphomas. The cyclophosphamide, oncomine means vincristine, prednisolone, procarbazine, all these things. ABBD is also there, adriamycin, vincristine, bleomycin, doxul, all those things are used for lymphomas. And so, yeah, ABBD 63, you have answered, R-CHOP also. So many regimes are there. In addition, of course, as somebody has pointed out, other these targeted antibiotics like rituximab, all those things are also given. So that is about gastric lymphoma. This is also for general awareness rather than it is not going to be a point. So of course, this disease is very important. This may be given as a 2-mark or 4-mark question. So Jollinger-Ellison syndrome, what is it? Previously, we used to think it is nothing but there is pronounced peptic ulceration. But later it is found it is due to the, hypergastrin, correct. So it is due to the gastrinomas, which will secrete gastrin. So this may be seen as a sporadic case only in the stomach region, or it may be part of the men syndrome, men type 1. So as a part of men type 1, gastrinoma may be there, or it may be sporadic. So there is what is called as gastrinoma triangle, wherein these gastrinomas are very common, so that whenever you suspect JE syndrome, you have to do scanning in that region to rule out gastrinomas. These are very small tumors can be there. So what is this triangle? Junction of cystic duct and CBD superiorly. Superiorly, CBD, cystic duct junction. Then inferiorly, second and third parts of duodenum. That is lower part. Then medially, neck and body of the pancreas. So this is the gastrinoma triangle. So this is the junction. Cystic duct and CBD junction. This is superior. And inferiorly, this is second part of duodenum and third part is starting. So this is the another junction inferiorly, and medially, this is the neck of the pancreas. So gastrinomas are very common in this triangle, and as it is given here, 90% of gastrinomas are located within this triangle. 90%, of which 50% are in the duodenum, mainly second part, and another 50% are in the pancreas. So the disease is somewhere and it is manifested somewhere. So disease is here, but it is manifested in the stomach as persistent peptic ulceration, which is actually, even with ordinary doses, it is not going to be relieved. So we are going to give, in place of 10 milligrams, we have to go 80 milligrams. So that much you have to give. Previously we used to give like that when we never knew that there was a gastrinoma there. So this is a gastrin producing endocrine tumor. So G cells are in Brunner's. When we discussed about stomach and duodenum, we have discussed about the Brunner's glands mainly seen in the duodenum and G cells. Even stomach also there are G cells, but it is common in duodenum. So there is persistent peptic ulceration. And with, so previously we used to do gastric output studies. So gastric function tests, we used to call them. And then we used to ask the patient to come on fasting, and we used to take insert trials tube and then aspirate completely and then find out how much is the basal acid. So it used to be very high. So I think I have a slide for that. Yeah, this is emptying studies. No. Okay. So very high basal acid output, and once we have suspected, we have to give a PPI and then rule out gastrinoma by doing CT scan. And and gastrin levels also you can estimate. If there is hypergastrinemia, then you have to suspect gastrinoma. So sometimes there may be even malignant also. So the treatment is surgery again. So you have to remove that either you can do enucleation of that gastrinoma, or if you are unable to do it, you have to remove the primary. So while removing the primary, suppose it is here, you have to do what is called as Whipple's operation, that is pancreaticoduodenectomy. This part of the pancreas and duodenum you have to remove, so that there may not be any recurrence here. But if it is small isolated, then you can do enucleation. Okay. So of course liver metastasis may also be there, and then because it is of indolent course, you can even remove the liver mets. Just in the other class I was telling you about metastatectomy of the liver mets. So that also you can do for JE syndrome, because it is mostly having a benign course. Okay. So JE syndrome is also important. And next we will go to the another topic, that is trichobezoar and phytobezoar. Already in part we have discussed this. So tricho means hair. So pathological ingestion of hair is what is called as trichobezoar. And if it is vegetable, then you call it as phytobezoar. So this is pathological. See, normally you and me will not ingest hair just like that unless we have some problem. So what do you call that thing that is having this peculiarity of ingesting whatever material, some materials like the rice, and even some people take even earth, mud also they will eat just like that. So what is that called as? Yes, good. So 140, 104, you are correct. It is pica. So PICA, pica. So that pathological ingestion of hair, and because it cannot be digested, and a lot of quantities daily, few strands of hair are taken in, so that it will remain in the stomach and it will be called as a hair ball. So young female psychiatric patients are more prone for this, and most of the cases it may just be like that, but patient may not take much food because of this air ball which is occupying entire stomach. But sometimes it can also lead to ulceration, bleeding, perforation, obstruction. All these can be caused by simple trichobezoar. So the diagnosis mainly, though it can be found out, you can suspect, and even mass may be palpable per abdomen, but rarely you may even find it by plain X-ray. But endoscopy is the diagnosis of choice, and you can enter the stomach and then see the ball, and then you can try to remove it through endoscopy, but sometimes you may need removal by surgery. So you have to do gastrotomy. So there may be hair ball like this, and then you have to open the stomach like this, and then remove the hair ball, and then close the stomach back. So that is called as gastrotomy. So after removing the hair ball, you can again suture the stomach back. So that is called as gastrotomy, and then remove it. So phytobezoars, already I told you, it is vegetable matter. Usually these, if the patient takes, gulps entire thing in one go, then this case is the problem. It may circumvent the esophagus, but in the stomach, it will stay back. But the mainly it is seen after surgery because it cannot negotiate the stoma. So phytobezoars are common after gastric surgery, and usually conservative. It may finally descend down, but if it is not so, then you have to remove by surgery again. So that is about trichobezoar and phytobezoar. This can also be given as a 2-mark question for you. Okay. So one thing you have to remember is these young female and psychiatric patients, they are more prone for this trichobezoar, right? Then all sorts of foreign bodies, already I told you, can be ingested. Most are seen on plain X-ray because most of them are metallic or some solid like buttons, pins, needles, everything can be ingested, and they are mainly removed endoscopically usually, but sometimes you may have to open. So one thing is most of them will pass normally. So only thing is you have to retrieve them in the fecal matter. The patient may give history that they have ingested this foreign body, even needles. So what you do is patiently master inactivity. So that's what gynec people or obstetricians will tell you. Masterly inactivity. Masterly means you should be carefully following the thing. So by, if necessary, serial X-rays you will take till it has reached the rectum, and then when finally it will be retrieved in the fecal matter. So once they pass stomach means they will be passed. Most of them will get stuck in the stomach if at all. So objects leaving stomach will pass spontaneously. That is the dictum usually. So sometimes the patient will come with particularly as a, not as a suicidal, but as a something, an effort. Suppose with husband, this patient got some fighting, and then what they will do is glass pieces they will ingest. The problem with glass pieces is bleeding because of sharp edge. Otherwise, they will be nicely passed down. So the patient will also give the history that yes, I have passed them. So that is the only thing. But immediately what you have to do is you have to assist spontaneous passage by giving her some laxatives, and the best one is because the sharp edge can be blunted by taking bananas. So you will advise them to take plenty of bananas so that this banana that will be coating the sharp edge and then making it somewhat smoother. So that you can do after the patient gives history of taking some glass pieces. So that is, it will become a medical legal case. So you should be careful. Just don't treat it alone. You have to make it at least enter in the accident register. Okay. So that trichobezoar is for young adults, female, whereas here this is also usually females and then adults with ill-defined psychiatric problems. So the tendency for emotional things like desire to take something drastic step. So that is the ill-defined psychiatric problem one may suffer. So then the treatment is only bananas. Okay. So another set of patients are there who relish attention. So they want sympathy, the patients. So that's why I have seen patients with, the other day I was telling you, serial laparotomy. So on the patient's abdomen, you will see these namas, like Venkateswar Swami namas. So the patient will be having all incisions. So midline incision, paramedian incision, left incision, like that. So serial incisions will be there, and if you have incised the old incision, the patient is not happy. They want a fresh incision. That's why these people, what they do is, particularly RMPs, the doctors, and other Patis doctors, they will incise up to skin and subcutaneous tissue and then close it. It is not laparotomy actually. So people are gullible, people are there who will be falling prey to these quacks, and then they will be giving incisions like that. So treatment is, as I told you, only expectant treatment. So you give plenty of bananas, it will be nicely passed. If not next day, the day next, it will be passed nicely in the stool. So only when there are symptoms and the FB you are following by serial X-rays, it is not going down, then you have to intervene. But even then it is very difficult to localize. That's why just if the patient is better, don't touch that patient. Give some assurance, not only to the patient, even attendants of the patients. That is, they are more anxious than the patient. Unless they see that foreign body that is ingested, they are not happy. So you give them work to collect the patient's stool and then ask them to search it for the foreign body. That is their daily routine. Okay. So that's about the foreign bodies in the stomach. So the medico-legal importance, already I told you about these foreign bodies. That is the glass pieces. Most of them will ingest glass pieces. Then another problem that is of the stomach is what is called as acute gastric dilatation. So this is the stomach will become completely atonic and dilates enormously, huge stomach. So the stomach normal size you know, and it will be enormously dilated. So the stomach may be like this. So enormous dilatation of the stomach will happen, and lot of fluid is there within the stomach, and so Nowadays, the tendency is not to aspirate, because this aspiration is leading to some problems. So we usually remove the right tube immediately after surgery, particularly if it is not on the stomach. But if it is surgery on the stomach and you have not kept nasogastric suction, then this gastric dilatation may occur. So one should be very careful, because the patient will be vomiting, massive vomiting will be there. It may be aspirated into the stomach also. And because of vomiting, there may be dehydration and electrolyte disturbance. So only suspicion is very important. So post-surgery, particularly on the stomach, we should always aspirate the stomach till you are happy that the stomach has gained its tonicity. Otherwise, it may become atonic and then huge gastric dilatation can occur. So immediately what you have to do is institute a huge large bore nasogastric tube, aspirate completely. While aspirating, the patient may go to further fluid depletion. So immediately you have to give fluid replacement. So that is very important. Of course, rarely there may be underlying condition, particularly if there is sympathetic paralysis like fractures of the spine. So all these things, you may have to institute Rayleigh tube for prolonged periods. Okay, so that is acute gastric dilatation. Nowadays it is becoming rarer, but we don't know. So we should be careful. We should know about the condition, about acute gastric dilatation, right? Then another condition that is very peculiar is just like you have heard about sigmoid and cecal volvulus, even small bowel valvulus. Stomach also can undergo volvulus rotation. So that is either horizontal, that is in the horizontal plane like this, or vertical like this. So vertical plane or horizontal plane, that is called as horizontal is organoaxial, or vertical is called as mesenteroaxial. So the stomach, so there are two fixed points here. So this is one fixed point. This is another fixed point. So the stomach may rotate like this, horizontally, or it may rotate like this, vertically. So either like this or like this. The stomach can rotate, and then so the pylorus and cardia are both fixed points. So around it they can rotate. Usually there is diaphragmatic herniation. Usually paraesophageal herniation will be there. So valvulus, though the term is sounding acute condition, it may be chronic also. So acute, then the patient will be giving a history of not able to eat properly. Whereas acute, of course, there is a chance of gangrene of the stomach. If the blood in volvulus, what will happen is, as already we have discussed, first there is venous, later arterial obstruction will be there, and this whole stomach can become gangrenous. Then you have no other go but to do a total gastrectomy. But usually the cases are chronic. And clinically, how to suspect is you cannot pass the Rayleigh tube. That is the typical thing, because the stomach is rotated. The patient will have problem in inserting this Ryle's tube. So that is the one that tells us that there is volvulus. But otherwise, if you do a contrast X-ray or CT scan, you will know that there is volvulus of the stomach and associated with diaphragmatic hernia. So the stomach will be in the chest, thorax. So what you have to do is do laparotomy and then reduce the contents in the stomach, in the thorax, and bring them to the abdomen, suture that defect in the diaphragm, and then you have to prevent recurrence of volvulus. So what you have to do is you have to fix the stomach. That is called as gastropexy. The commonest one which we do is simply do GJ, gastrojejunostomy, anterior gastrojejunostomy, so that the stomach cannot move. So you bring the jejunum like this and then do anterior gastrojejunostomy, so that stomach will no longer rotate. So that is called as actually anterior gastropexy. It can be done to the parietal wall, but we prefer a gastrojejunostomy. Another thing is both stomach and colon need to be separated. Otherwise, the stomach will take along with it the transverse colon also. That will also be gangrenous. So you have to separate them, and then you can do GJ, and then as I told you, you have to close the diaphragmatic defect with a mesh. So that is volvulus of stomach. This is also important condition which you have to remember, though it is not for your exam purpose. This is also one of the important conditions of the stomach. So that's about this remaining conditions of the stomach. So once again, what are all the conditions? Just let us enumerate. So gastrointestinal stromal tumor, mainly this is previously called as leiomyoma or leiomyosarcoma even, but we don't call it as that now. It is GIST only. The treatment is surgery, and you have to exclude malignancy by means of size and mitotic index and metastasis. So gastrectomy and imatinib, these two things you have to remember. Then going to lymphoma, this is increasing because of H. pylori infection, and they form about 5% neoplasms. So one thing you have to exclude is generalized lymphoma. Once you have excluded means, then you can do surgery, some form of gastrectomy. Whereas for generalized, you have to give chemotherapy. Then JE syndrome, you have to remember about this gastronoma triangle, and treatment with either PPI or best is resection of the primary, and if there are liver mets, even that are removed. So this is the gastronoma triangle. Then you have trichobezoar, so psychiatric patients, ingestion of hair or vegetable, you have to remove by endoscopy or rarely by surgery. And foreign bodies also same. You have to expectant treatment is very, very important. And if they are not moving, then rarely you may have to intervene by doing gastrotomy. So acute gastric dilatation post-surgery, very common. So you have to treat it with nasogastric suction with a large bore needle, not needle, tube, and fluid replacement. Electrolyte disturbance also need to be corrected. And volvulus, two varieties, horizontal, vertical, because of two fixed points. So both cardia and pylorus. In our childhood, I don't know whether you played or not, we used to play with these uh, bottle covers. So all these nowadays there are thumbs up and all. Previously only we used to have gold spot. So there used to be one gold spot Murthy here, who was the chairman of Geetam. So MBBS Murthy. So he is no more, of course. So with that, we used to play this like this valueless only rotation. We used to tie a thread to it and then play with it. So like that, this valueless can occur. And then usually it is associated with the herniation. Okay. So the treatment is immediately have to open and then reduce the contents like a hernia, and then try to prevent recurrence by doing a gastrojejunostomy and then close the diaphragmatic defect. Okay, so that's it for today. Hope you are all preparing for tomorrow's exam. So it will be of 2 hours, as all of you know, and hope you are all preparing well, and all the best to you. So any doubts if you have, you can ask me in today's topic. So next class, we will start pancreas. It may take 2 to 3 classes because it's very important. You will get essay question also in pancreas, that is acute pancreatitis. And with increasing incidence of malignancies, you have to know something about carcinoma of the pancreas also. And in addition, there is another entity that is very important in surgeon's point of view is chronic pancreatitis. So we'll discuss in 2 to 3 classes the pancreas. With that, I think we'll be finishing our course. Okay? Yes. Yeah. What is the enzymatic digestion for treatment of trichobezoars? And yeah, that's what I was telling you. Though trichobezoars are not digestible, if you try to give some drug, not the hair, but the mucosa will be digested. So don't try to ever to give this enzymatic, think of enzymatic degradation. But of course, phytobezoars definitely because of the acid and other substances in the stomach. So as you know, stomach will digest, the early part of digestion is in the stomach. So they will definitely help in phytobezoars, definitely. That's what I told you. Phytobezoars, you can either wait expectantly or remove with endoscope. Whereas trichobezoars definitely need treatment either endoscopic or surgery. Okay. But don't try to treat them medically. That is very important. Always observe them, and then particularly trichobezoars immediately have to remove. Otherwise, patient has no place for the food storage in the stomach. That's why patient will become very thin and lean. Okay, not able to take properly diet. So once you remove this trichobezoar and then treat the psychiatric condition, the patient will become obese also sometimes. So that also you have to be careful. Okay. Yes. Anything else? So for all the things in today's class, you have to remember trichobezoars and JE syndrome. Both of them are 2 mark questions for you in the exam. Okay. Right. Okay. Thank you. We'll stop here for today.